Hi, everybody. Dr. Horn with infectious disease. We're going to talk today about pneumonia antibiotic de-escalation. So this is a question that we get a lot. When patients are started on something for pneumonia, and is it okay to de-escalate? Is it not? If the patient is started on something and the next day they're doing a bit better, sometimes it makes people a little bit nervous to change antibiotics, especially if they're improving and you don't have any organisms yet that have been identified. So first, we're going to talk about, uh, starting what antibiotics to start if somebody has community-acquired pneumonia, hospital-acquired pneumonia, ventilator-associated pneumonia, what to start, and then kind of going from there. What factors would help de-escalate, change antibiotics, and not continue on the same course that they were started on from the beginning. So if you have any questions, please type it in the chat, and I'll see if I can get everything answered. So why pneumonia? So why are we talking about pneumonia and antibiotics? So antibiotics in hospitals oh, generally in the hospital, you look at, what are the biggest causes of people getting antibiotics and broad spectrum antibiotics and overuse of antibiotics. Well, pneumonia is a big one. So that's why we're going to start here. High rates of broad therapy, giving antibiotics that are way over what is needed, not only the spectrum, but the duration. So de-escalation, when we talk about de-escalating, we're talking about a narrow spectrum. So sometimes family members will say, and really healthcare workers also, they'll hear de-escalation and they'll think not as effective or not being aggressive, and they'll think, we don't want to de-escalate. That's we want to continue aggressive treatment. And so instead of saying de-escalating, sometimes it's better to say narrowing. We're going to narrow antibiotics, narrow the spectrum, more selected treatment directed towards the specific organism, if you know it, or taking out spectrum that you don't need. So, when you go from three antibiotics to two or to one, I try to say to the family, try to say to the family that we don't want to give them anything that they don't need, because giving people things they don't need increases harm and doesn't improve outcomes and isn't a benefit. So when you think of the pros and cons of giving antibiotics, we want to give people just what they need, and also just for the number of days that they need it. So the duration of antibiotics, the longer of duration of antibiotics that you give, the benefit decreases and the harm increases. So when you're thinking of duration of antibiotics just in general, you know, failure to improve and outcomes aren't necessarily based on duration. When you think of the benefit is mainly choosing the right antibiotics up front, and it's delay of the correct antibiotics. Delay of antibiotics that would work is way more important than duration of treatment or dose or anything, you know, uh, related. It's going to be choosing the right antibiotics is the most important thing up front. And when you think of the benefit, the benefit of antibiotics, and the longer you have antibiotics on, uh, the benefit goes down and the harm goes up. It's similar to alcohol or drugs. So the longer you're, drinking, or the longer a person drinks or does drugs, um, the benefit goes down, 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 and the harm goes up, 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 right? I'm saying these things as a way to remember, right? HCAP, HCAP is gone. So I know there are some hospitals that I get a call, or some clinicians that I get a call, and it's HCAP is still being used, and it's been gone for a little while. HCAP is healthcare associated pneumonia. So this is a term that where they would try to label and identify patients that might have organisms that have a high amount of resistance. So they tried to say that if patients had been in a healthcare facility within so many days, including dialysis centers or if they've been in a healthcare facility, then the likelihood of them having a multi-drug resistant organism might be increased. And so they recommended treating everybody for multi-drug, uh, either multi-drug resistant organisms or including MRSA, Pseudomonas, and these type of things. But most patients labeled as HCAP did not have resistant pathogens. So there were large scale studies that were done, and they said they looked at patients that would be considered HCAP, and did they have different organisms? Did the HCAP label uh, was it helpful to identify patients that needed broader antibiotics when they were treated? And that's not true. It didn't identify they had the same organisms, and then um, so they didn't need more broad treatment. So what did it led to um, patients getting overly broad antibiotics, and it did not improve survival. It did not help outcomes. It did increase complications. So no longer use HCAP. When you're looking at, where did I come up with the recommendations that I'm going to be talking about today? It's going to be mainly looking at the guidelines. So the guidelines are, there are several. Some of them, well, one of them is for community-acquired pneumonia. This is from 2019, and the other is for uh, hospital-acquired pneumonia and ventilator-associated pneumonia. And so there are two different guidelines, and they're not all encompassing. Today's talk isn't meant to be all encompassing. It's meant to focus on antibiotics and what antibiotics to choose. And most most common etiologies of community-acquired pneumonia. So when you're thinking about what antibiotics to give for any condition, the best way to do it, although it's difficult, is to think of not the type of infection, not like community-acquired pneumonia. Oh, these are the antibiotics that are given for community-acquired pneumonia. It's better to try to think of it as what organisms am I trying to cover, and then what antibiotics should I choose to cover those organisms. So same with a cellulitis. Instead of thinking this antibiotic isn't used for cellulitis, or isn't, one of the top ones people talk about, or you have association, it's better to think of they have a cellulitis, what organisms would cause that, then what antibiotics would I give to cover those organisms? Because antibiotics kind of get linked with certain diagnosis. Like if you think of this antibiotic is only given for this indication, it's better to think of what organisms am I trying to cover? So the organisms haven't changed. This is from the uh, 2007 guidelines. Most common etiologies of community-acquired pneumonia. So whatever you give, you want to make sure that you're covering the most common causes. And this is community-acquired pneumonia, and then uh, the patient type. This patient type, whether it's outpatient, inpatient, or inpatient ICU, has been kind of revamped, and I'll talk about that in a second. But the organisms haven't really changed. So when it comes for patients coming into the hospital or into the clinic with community-acquired pneumonia, the most common is going to be strep pneumoniae. So whatever you give, you want to make sure that you're covering strep pneumonia very well. And then inpatient, also strep pneumoniae. So this is a patient acquired, they got pneumonia in the outpatient setting, and they're being treated outpatient. You think of these causes. Inpatient, you think of these. And then they're sick enough to be in the ICU, you can think of these causes. And if you look, the most common is going to be strep pneumo across the board. And then if they're sick enough to be in the ICU, it adds Staph aureus, Legionella, some gram negatives. Now, the updated guidelines, the organisms haven't changed, but they wanted to focus not on where the patient is being treated, because in some hospitals, you know, they might be uh, whether they have an ICU or not, or whether the patient is in the ICU, but they're actually not ICU status or not ICU level. They didn't want to say treat them based on where they are in the hospital. They wanted to focus on the patient and how sick is the patient and what type of patient should you treat in what way. So instead of saying based on their location, they recommend going off of the definitions that show how sick the patient is. So defining severe community-acquired pneumonia. So instead of saying if the patient, they're outpatient, so they're probably not severe, or they're inpatient non-ICU, so they're probably not severe, it's better to characterize that based off of the factors of the patient. So here there, and this is from the 2007, but the updated guidelines actually refer to the 2007, this criteria for defining whether it's severe or not. So validated definition includes either one major criterion or three or more minor. So let's skip to the major. Here's the major criteria for defining if they have severe pneumonia. So septic shock, need for pressors, that's severe, or intubation. So if they're intubated or they have septic shock, that's severe. That's pretty straightforward there. Minor criteria is all this stuff. And um, yeah, so I'm not going to go through all this stuff, but you can see, you know, it's probably just most important to think of the major criteria here. Now, community-acquired pneumonia, initial antibiotics. So this is kind of a long chart. We're going to start on the left and then move to the right. Great. And then there's a question in the chat. Yeah, good. I'll get to that. It's the question is if cultures are late returning, patients improving, when is it okay to de-escalate? We have to send cultures off site. Sometimes it may be 4 days or longer to get results. Yeah, that's a great question. And that's a common issue. So yes, we will talk about that. Now, this is the initial antibiotics for inpatients with community-acquired pneumonia by level of severity and risk for drug resistance. So we're going to start on the left and then we're going to move to the right. So on the left, you can see it's non-severe or severe. And that's based off of what we just discussed in the last slide. So how severe are they? In general, you can kind of think of are they in the ICU or not? So that's septic shock or um, intubated versus non-severe pneumonia. So the first standard regimen, so non-severe or severe is going to be the same. So a beta-lactam plus a macrolide. Question about that. So why do we do beta-lactam plus macrolide? It's because the outcomes are better, is the bottom line. So uh, that's going to be generally ceftriaxone plus azithromycin. Um, People usually say their macrolide is for atypicals, which, okay, the studies also show that strep pneumo, which is the most common cause of community-acquired pneumonia, outcomes are better if you use beta-lactam plus a macrolide for strep pneumo. So if outcomes are better for the most common organism with a beta-lactam plus a macrolide, that's really the main reason why we give ceftriaxone plus azithro. It's essentially to give two antibiotics to cover strep pneumo very well. Why that has such a big effect, like why there's a mortality benefit for treating strep pneumo with two antibiotics is kind of odd, right? So they look at it and they say, why is that? And I believe that in a test tube, when they grow it, in the lab, when they use beta-lactam plus macrolide, I don't think it has a difference between a beta-lactam alone. So then there's a question, well, why would it work in a person and not, when they test it on the bench? I think that people usually say something like, well, maybe the macrolide has some anti-inflammatory properties, which might be the case, but also, um, you know, the harms and benefits of giving steroids for pneumonia. We won't actually go into that in this presentation, but there are some studies showing that if you give steroids to severe community-acquired pneumonia, that the outcomes are better. And a lot of that depends on the case, right? Case by case for when would steroids be helpful and not helpful. But in general, here beta-lactam plus a macrolide helps with strep pneumo. So what does that mean? That means if you have a patient that's very sick and you have it identified as strep pneumoniae, and you have a susceptibility report and you show that it's susceptible to the ceftriaxone that you're giving, I would keep the azithromycin there at least for several days because it improves outcomes. So um, when we talk about pseudomonal coverage and giving two antibiotics for Pseudomonas, we give two antibiotics for Pseudomonas because we're essentially hedging our bets. We're trying to bet that one of the antibiotics that we're giving is going to work in hospital settings where there's a lot of resistance to for their Pseudomonas to different antibiotics. So if someone has Pseudomonas, what is the likelihood you're going to have resistance to one of the antibiotics you're giving? But once you identify that and you get a susceptibility report of that Pseudomonas, once you see that what works, you can go to one antibiotic alone. So you don't need to give two. You're essentially giving two because you're hedging your bets that one of them will work. Once you see that one works, you just go with that one. With strep pneumo, it's a little different because even though you see that ceftriaxone works, you would keep the azithromycin on to give two because it helps with outcomes. Now, beta-lactam plus macrolide or a respiratory fluoroquinolone. Respiratory fluoroquinolone is essentially just meaning a fluoroquinolone that also has some gram-positive activity. So respiratory fluoroquinolones, you're thinking levofloxacin because it covers strep also, but not ciprofloxacin. So you wouldn't be giving Cipro for a pneumonia. That wouldn't be a good plan. But you can be giving levofloxacin, you can be giving moxifloxacin. Now, so that's not a lot of people, including myself, aren't thrilled with uh, the recommendation to give giving a fluoroquinolone for community-acquired pneumonia. But here, this is probably in people that have a beta-lactam allergy, and you're trying to decide what else to give. Um, Prior respiratory isolation of MRSA. So if the patient has a history of MRSA, like they're colonized or they've grown MRSA before, then add MRSA coverage and get cultures, nasal PCR to allow de-escalation. So that's both for non-severe and for severe. You would add MRSA coverage because if they had it before, they likely have it again. So you'd add MRSA coverage. Prior respiratory isolation of Pseudomonas, same thing. Add coverage of Pseudomonas for both non-severe and severe. So if they've had it before, you would add coverage for it. Now, if they've had it before, you can also look at the susceptibility report of what they had before and and go off of that. Now, recent hospitalization with antibiotics and locally validated risk factors for MRSA. So, and we'll talk about what the risk factors for MRSA, what they are. The main one is just essentially the same here. It's that they've been getting antibiotics in the last 3 months or so. So here, this is dependent on how sick they are. So if they have a recent hospitalization with IV antibiotics, how sick are they? So if they're non-severe, if they're not that sick, you can get cultures, you can check PCR, but you don't necessarily have to start uh, anything right away. You would withhold MRSA coverage unless it's positive. So you're looking here and you're saying if they're not that sick, we can test them, but we don't have to start anything right away because you have time to see what the test result is. But if they are very sick, then you would add MRSA coverage and then you would also test them. So we don't have time to wait for the PCR. Let's start coverage, and then if it's negative, stop. right? And then here you have essentially the same thing with Pseudomonas. If they're not that sick, you can get cultures and then start pseudomonal coverage if positive. If they're very sick, then you want to start pseudomonal coverage and test at the same time. So kind of a long chart, but they wanted to emphasize risk stratifying, how sick are they, um, and what's the likelihood that they have resistance instead of recommending broad therapy for everybody. Okay. So it's kind of a long chart, community-acquired pneumonia. I do want to emphasize MRSA nasal PCR. So PCR of the nares is excellent, and it's very good at its negative predictive value. So if you do a MRSA PCR nasal swab and it's negative, then that means you can stop MRSA coverage, which is very good. So really, anyone that's getting admitted to the hospital and vancomycin, or they're in the hospital, if vancomycin is being started for pneumonia, really, I'd recommend if you're starting vancomycin or MRSA coverage for pneumonia, also at the same time order an MRSA PCR. And if it's negative, that means you can stop the vancomycin. Now, this is for pneumonia. So it is really high negative predictive value for pneumonia. I often get questions about what about other infections besides pneumonia? If the MRSA NARES PCR is negative, can we stop MRSA coverage on a diabetic foot? Can we stop it on, any other kind of wound? And that's a good question. That's a good question because there are some studies that say that the negative predictive value is good in other type of infections, like foot infections. Although I don't recommend adjusting antibiotics unless it's a pneumonia. And the reason is because there are some articles that came out that said MRSA PCR NARES has a high negative predictive value for foot infections and other wounds. And it was kind of discussed among ID people. Uh, the EIN, the Emerging Infections Network, is kind of where ID people go, and they can discuss, what they're seeing in their area. Are they seeing outbreaks? Or they have difficult cases? And then getting feedback from other infectious disease people. And there are some hospital networks that they decided to do the same thing with foot infections and other infections, other places on the body other than pneumonia. They decided to institute this where they would say if the MRSA NARES is negative, then you can stop MRSA coverage. Um, Although there were some places that got burned. So there were some ID doctors that said, yes, they did that in our area, and then we had a really bad outcome, and we stopped doing that. And that's kind of how I think of it is I don't really trust, that an MRSA NARES PCR for other types of infections like foot infections. And I know a lot of my partners agree with this sentiment because you don't necessarily need to be colonized to get an uh, MRSA wound infection. And then we also have another question. Uh, has been a recommendation for Rocephin plus doxy for atypicals due to azithro resistance in the community. Can I speak to that? Yes. Um, yes. So azithromycin, it depends where you are. I think now I agree with that, first of all. So azithromycin in Nebraska, I believe, and years ago, the resistance, strep pneumonia resistance to azithromycin was somewhere around 68%. Um, sorry, uh, I could say the likelihood that it would work is around 68%. So the resistance was around 30% or so, and that's high. So, recommending azithromycin for community-acquired pneumonia alone in areas with high resistance to uh, with strep pneumo, high resistance to azithromycin, um, is makes me a bit uncomfortable. So yes, and the other reason to recommend Rocephin plus doxy would be that doxycycline covers MRSA very well, and it's very well tolerated. So you could give Rocephin plus doxy, and you would also have that same effect, right? So when they did the two antibiotics, the beta-lactam, the ceftriaxone plus azithro, um, the two antibiotics had better outcomes with strep pneumonia, but also the other antibiotics they tested also had the same result. So if they gave two antibiotics, they had better outcomes. So it wasn't only ceftriaxone plus azithro, it was also ceftriaxone plus levofloxacin, and I believe they also did ceftriaxone plus doxycycline. So giving the two antibiotics, as long as it was two in those some of those studies, there was a Mayo Clinic study, they had better outcomes. So yes, I do agree with that. The doxycycline would cover MRSA. Also in patients uh, that have uh, a viral respiratory infection, like if they have influenza or RSV or something like that, and then they get a pneumonia, like a bacterial pneumonia, the likelihood of MRSA increases. Staph aureus and MRSA increases for getting a secondary bacterial pneumonia on top of your viral pneumonia. And in those cases, the likelihood of MRSA increases. So you want to give something that covers MRSA. So if you're giving Rocephin plus doxycycline, that would be a good plan in someone that has an influenza, and then they acquired a bacterial infection on top. Now, when it comes to hospital-acquired pneumonia and ventilator-associated pneumonia, this is what we're going off of here. This is 2016. This is for uh, what we're going to be talking about when we talk about hospital-acquired and ventilator-associated. Now, hospital-acquired pneumonia is defined as pneumonia not incubating at the time of hospital admission and occurring 48 hours or more after admission. So this is someone that got admitted to the hospital, and then while they're in the hospital, they develop a pneumonia. And these terms, these definitions, uh, like are used because it changes the organisms, right? And it changes what antibiotics you want to give. So when you think of hospital HAP, when you think of HAP, how does it change the organisms? So we had the organisms for community-acquired pneumonia. I don't have them here for hospital-acquired pneumonia, but the organisms change because it increases the likelihood of having Staph aureus and MRSA, and also increases the likelihood of gram negatives like Pseudomonas. Now, ventilator-associated pneumonia is defined as pneumonia occurring greater than 48 hours after getting intubated. So risk factors for multi-drug resistant pathogens. So risk factors for MDR, ventilator-associated pneumonia, prior IV antibiotics within the last 90 days, septic shock at time of the VAP, ARDS, preceding VAP, 5 or more days of hospitalization prior to the occurrence of the VAP, acute renal replacement therapy prior to VAP, and then um, prior intravenous antibiotic use within 90 days. So that was the same as before with the MRSA. So if they've gotten antibiotics in the last 90 days, risk factors for multi-drug resistant Pseudomonas, it's also the same. So generally, I'm a lumper and not a splitter. I try to lump things together as much as possible, and you can see that all of this is, if they've gotten antibiotics in the last 3 months, that puts them at risk for all of these things here. Hospital-acquired pneumonia. So here's the definition again. And then again, we have a really big table. So we will um, go through this one, and we'll start on the left. So this is the initial empiric antibiotics for hospital-acquired pneumonia, non-ventilator associated. So they got this 48 hours after being in the hospital, not at high risk of mortality, and no risk factors for MRSA. So that's going to be the first one. This is not high risk of mortality. The next one's not high risk of mortality. And the next one is high risk of mortality with IV antibiotics in the prior 90 days. So it's if you think of not at risk, or sorry, not high risk mortality, and they don't need MRSA coverage, not high risk mortality, they do need MRSA coverage, and then high risk mortality, you just want to cover them really well. So the first one, not high risk of mortality, no risk factors for MRSA. So that means you pick one. So you can give piperacillin tazobactam, which is Zosyn. So Zosyn or cefepime or levofloxacin. Um, Now with this, you're essentially choosing, um, you know, and I will say across the board, if you can give a beta lactam, that would be the best thing, right? So anytime we're choosing antibiotics for any reason, not only pneumonia but anything, if we can choose a beta lactam, that would be the first choice because people do better on beta lactams because beta lactams kill the bacteria very quickly. So here, if we could choose a beta lactam, that would be what we'd want. Otherwise, if they have an allergy or something that prohibits that, you'd be giving levofloxacin. Now, the next one, not high risk of mortality, but with factors increasing likelihood of MRSA. So you give essentially the same, you can choose one of the same, plus something that covers MRSA. So vancomycin or linezolid. In general, I like linezolid a lot because it doesn't hurt the kidneys. And outcomes are also good with linezolid. And also you can give it PO. So, if they're doing well on it and you wanted to continue it and they're going to leave the hospital, you can just go to a pill form. And then with vancomycin, you'd be giving vancomycin in the hospital and then you have to choose something else PO. Um, but vancomycin, if anytime someone's getting vancomycin, I'm wondering about their kidneys and hoping I don't hurt their kidneys. So I try not to give too much vanc if I can. And then the next one is high risk of mortality, or they've gotten IV antibiotics in the previous 90 days. So you can see it says choose two of the following. Avoid two beta lactams. And now two of the following, we'll talk about what puts a person at high risk for resistant Pseudomonas in a minute. But if you're choosing multiple antibiotics, ideally you would choose multiple antibiotics that have a different mechanism of action. And that's why you're not going to choose two beta lactams. Now, the reason for that is because if you choose an antibiotic and um, it has resistance to that antibiotic, then you don't want to choose a second antibiotic that has the same mechanism of action because then it would be resistant to that too. There's also this thought that if you're giving two that have the same mechanism of action, that it might actually, if they're competing for the same receptor, you might actually um, not be helping yourself and the antibiotics might not work as well, is another thought. But anytime you're choosing multiple antibiotics, you want to choose different ones that work different ways. So two of the following. So this is Zosyn or cefepime or levofloxacin. Um, Here it says ciprofloxacin, and that's because you're targeting Pseudomonas. So you can give something for Pseudomonas coverage, but you're going to also additionally going to have um, something that's covering gram positives. So you're going to choose one. So frequently people will choose Zosyn plus levofloxacin. And then down here, you get down here and you choose plus something for MRSA coverage. So vancomycin or linezolid. So frequently, this is why you see vancomycin plus Zosyn plus levofloxacin. This is for hospital acquired pneumonia. So the reason here is that you're giving something for MRSA coverage like vancomycin, and then two things to cover Pseudomonas, Zosyn and levofloxacin. Um, Now, this is um, the same coverage a person might give for a community-acquired pneumonia, vancomycin, Zosyn, um, plus levofloxacin, although the reason is different. So if a person has a community-acquired pneumonia, and you're giving that regimen, the reason is that you're covering for MRSA just the same way here, but then and then you're giving Zosyn, and then the levofloxacin, you're actually giving that to cover Legionella if it's a community acquired pneumonia on that regimen. And it takes us back to the organisms that we looked at before, where if a person is coming in community acquired pneumonia in the ICU, Legionella is one of the reasons, uh, one of the organisms that pops up on community acquired pneumonia requiring ICU. So you're giving the same regimen, but the reasoning is a little different. Ventilator-associated pneumonia. So it's defined as pneumonia occurring greater than 48 hours after they've been intubated. So, and I referenced this a little bit before, when you're choosing pseudomonal coverage, you're going to choose, you might choose, uh, this is 2 antibiotics to cover Pseudomonas. And this is addressing when would you do that or when is that needed? So in ICUs where gram-negative isolate resistance rate are low, so less than 10% of the gram-negative isolates are resistant to the agent being considered for monotherapy. And patients have no risk factors for antimicrobial resistance. One anti-pseudomonal antibiotic may be given. So this is where you might give something like Zosyn alone. In ICUs where gram-negative isolate resistance rate is high, so greater than 10%. So that's when you would give 2 anti-pseudomonal antibiotics. That's where you might give something like Zosyn plus levofloxacin or meropenem plus levofloxacin or cefepime plus levofloxacin. Generally, you're trying to hedge your bet and try to hope that one of those is going to work, right? Now, this is based on a hospital antibiogram. So an antibiogram is where they take all the organisms that were identified in that hospital in the last 2 years or so, and then um, give you a report and show resistance rates. So if you know your resistance rates and you know that, in your hospital, for example, cefepime works 95% of the time, then you wouldn't need to give 2 different antibiotics to cover Pseudomonas. You can just give cefepime alone. So here's your ventilator-associated pneumonia table here. These are suggested empiric treatment options for clinically suspected ventilator-associated pneumonia in units where empiric MRSA coverage and double pseudomonal gram-negative coverage are appropriate, right? Because that's where you would need a big table like this. So the first part, and here I'll choose one gram-positive option from column A plus, oh, it's coming out stepwise. So 1 gram-positive option from column A, gram-negative option from column B, and 1 gram-negative option from column C. So this is the same kind of thing that we just looked at, where you want to cover gram-positives with MRSA activity, so vancomycin or linezolid, plus an antibiotic, gram-negative antibiotic with anti-pseudomol activity. Basically, you want to get a beta-lactam and then a non-beta-lactam. So for instance, Zosyn plus levofloxacin, or cefepime plus levofloxacin. So, and we discussed the reason for this before. So, a beta-lactam anti-pseudomonal, non-beta-lactam anti-pseudomonal. And then once you've identified it, if you have a sputum culture or if you have something you can go off, a BAL, then you can tailor antibiotics. So you can just go with the one. So once you know that it's Pseudomonas, for example, and Zosyn will work, you can stop the MRSA coverage. You can stop the additional um, Pseudomonas antibiotic, and then just choose one antibiotic to go with. Additionally, if your MRSA NAIRS is negative, then you can also de-escalate. Now, I do want to say that while we're talking about fluoroquinolones, fluoroquinolones are very good. In general, we try to limit the fluoroquinolone use overall, and that's to prevent C. diff, issues with aneurysms, issues with increasing resistance in gram-negatives, tendon rupture, QT prolongation, drug-drug interactions, all of these reasons. Another good reason is that when they look at antibiotics and pneumonia, there's a lot of evidence, like I was saying before, that beta-lactams are better. So if you have a choice between giving something like ceftriaxone or levofloxacin for an organism that is susceptible to both, ceftriaxone wins, right? You have better outcomes and fewer problems with it. So while I'm mentioning all this stuff about fluoroquinolones, it's good to say that we try to reduce the amount of fluoroquinolones that are given overall. And duration. Uh, this community-acquired pneumonia is 5 days total, and hospital-acquired and ventilator-associated 7 days total. So you would essentially reevaluate them at day 5, or and say, are they improving? Are they getting better? And if they are, you would stop. If they're not getting better or worsening, you wouldn't use these durations. Um, there was a question earlier about when it's okay to de-escalate. If you don't have microbiology data, I would say if the patient's getting better, it's okay to de-escalate. If there's been some clear improvement clinically, it's okay to de-escalate. Another thing that you can use to de-escalate would be procalcitonin. Procalcitonins are very good. They correlate with bacterial infections, and the uh, the number also correlates with severity. So if you get a procalcitonin, there's a patient I saw today in the hospital. Procalcitonin was 22 yesterday and it's 11 today. That's exactly what we would want to see, that it's cutting in half every day. Now that would correlate with a patient that has a bacterial infection on the right antibiotics. So if you are considering pneumonia in someone and it's unclear, procalcitonin can take a while to increase. So I wouldn't use procalcitonin to start antibiotics, but I would use it to stop antibiotics. So if I kind of think of it like a troponin, like it takes time for it to get elevated. Okay. So if they've had an issue going on for a long time, the procal should be elevated. But if that day they started feeling sick and you check a procalcitonin and it's not elevated, I would still treat for pneumonia with your clinical suspicion. But if you repeat a procalcitonin the next day or so, it should be elevated. And if it's not elevated, if you have two low procalcitonins, I would consider a different diagnosis that it would decrease the likelihood that they have pneumonia and to consider other things. Now, I do want to mention also shorter is better. This is uh, Dr. Spellberg, Brad Spellberg's website. And this is not only for pneumonia, but other things as well. And so you can see shorter is better. It's not shorter is the same, although the result here, they'll look at community-acquired pneumonia, short, so 3 to 5 days of treatment versus long, 5 to 12 days. The result was equal, and the number of randomized controlled trials is 14. So shorter is better because if you decrease the number of days of antibiotics, that's better. You're not getting all the issues with all the badness from antibiotics. You're just getting the benefit. So shorter is better, although here they say equal. And lots of randomized controlled trials that, as they do more and more studies, the durations go, from 2 weeks down to 3 to 5 days. This is also has it for ventilator-associated pneumonia here. So 10 to 15 versus 5 to 8, they're equal. And they looked at large numbers. So I just wanted to cut and paste some of the evidence here because sometimes I get some pushback. Every once in a while, someone will push back and say, no, I've been treating pneumonia for 30 years. I give 2 weeks. And I'll try to ask if I can send you some evidence. And you can see that it's the total of 8,732 patients looking at all these randomized controlled trials, and shorter is the way to go. And here's ventilator associated. There are lots of patients in this one as well. And they have ultra short, which is 3 days in patients that have ventilator associated pneumonia, and they also had very good outcomes. So that goes along with what I was saying, that the choice of antibiotic up front is the most important thing rather than duration. Is there a value in getting MRSA nasal PCR after MRSA coverage has already been started? Um, oh, this is a good question. Yes, I would still get it. So because it's PCR, you're not counting on it to grow in culture. So even if it were dead, um, even if it's dead organism, the PCR should still detect it. So if it was there, it's still good. So yeah, that's a great question though. All right, any other questions at all? So it's kind of a lot of information. This we'll have this available to people so they can look it up and reference it. Or if you want to, the go straight to the IDSA guidelines, that works too. The guidelines aren't all encompassing, but it's a good foundational thing that to get to what people agree on because they have a large number of people that have to agree on the guidelines. So it's good for foundational, but you wouldn't need to follow it, to the T sometimes. All right. If anything comes up, you can always contact me or specifically on uh, patient questions. Please feel free to reach out anytime, and we can help with whatever you need. Thank you very much, everybody. Have a good day.